Good afternoon or good morning, depending on where you're located. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I will be your moderator for today's education event, Advancing Health Equity and Justice for All. Just want to let you know that the webinar presentation will be approximately 70 minutes, followed by a 20-minute question and answer period that I'll moderate. So during the presentation, I encourage you to type in your questions using the question mark widget to the left of your screen at any time, and we'll try to get through all those questions, or as many as we can, at the end of the presentation. The recording of this webinar will be available on demand and in the coming days on the college's website under our Continuing Education tab. I now want to introduce our speaker. Nandini Saxonaya is our speaker for this afternoon, and while her full bio is available on the platform, I would like to say a few introductory words. Nandini is a registered social worker in Ontario and has over 20 years experience in policy, research, public engagement, knowledge mobilization, and health and system improvement. She currently works with the National Collaborating Center for Determinants of Health as a knowledge translation specialist. Nandini, I'm really looking forward to your presentation, and I was so honored when you agreed to do this presentation for us. And on that note, I'm going to pass the virtual podium over to you.
Thank you so much, Annette. I really appreciate that introduction, and I also really appreciate your invitation to present not only through the Newfoundland and Labrador College of Social Work, but also through the Canadian Association of Social Workers. So while I'm presenting, I will turn off my camera, but you will obviously see all the slides. And then when we get to the Q&A session, I will turn my camera back on. And I just also want to say that I'm so excited to be engaging with social workers across the country. Social work is a profession that has given me many amazing opportunities, and I'm very grateful to be a social worker. So on that note, I'm just going to share with you this overall session. And the focus of this session is on advancing health equity and justice for all. So as Annette mentioned, I work with the National Collaborating Center for Determinants of Health. And as a way of starting us off in a good way, I'll share a land acknowledgement. So the NCCDH is located in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqiyik peoples first signed with the British Crown in 1725. These treaties do not deal with the surrender of lands and resources, but recognize Mi'kmaq and Wolastoqiyik title and establish the rules for what is to be an ongoing relationship between nations. I live, work, and play in Toronto, which is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Wendat peoples. This land is still home to many Indigenous peoples from across Turtle Island, and this land is covered by Treaty 13, established in 1805 at a time when Black people, forcibly brought to Turtle Island through the transatlantic slave trade, were enslaved or actively resisting enslavement in what is now known as Ontario. So through this land acknowledgement, I'm also really sharing with you that disrupting settler colonialism, white supremacy, racism, and other different forms of structural drivers of health inequity are very much a part of the NCCDH's health equity work. So giving you a bit of organizational context. So as Annette mentioned, and as I've mentioned, I work with the National Collaborating Center for Determinants of Health. So we are one of 6 national collaborating centers for public health located across the country. So we're funded by the federal government, by the Public Health Agency of Canada, and we were set up after SARS. And our mandate as a group of 6 NCCs is to promote and support the use of scientific research and other forms of knowledge to strengthen public health practice programs and policies across the country. So we each focus on a specific public health priority, whether that's environmental health, Indigenous health, knowledge translation methods and tools, Healthy Public Policy, Infectious Disease, and my organization, The Determinants of Health. And I want to emphasize that while our primary audience is public health, we do actively engage and work with many other partners, sectors, and professions, including, importantly, social workers. So we are here for you. And if you have any questions, either during this presentation or afterwards, please do feel free to reach out. So a bit of information about the NCCDH. So our focus is really on enabling public health and other sectors and professions, including social workers, to enable action on the structural and social determinants of health to improve population health and achieve health equity and justice for all. So we're really about supporting people to put knowledge into action to advance fair opportunities for health. We are hosted by St. Francis Xavier University in Antigonish, Nova Scotia. So the learning objectives for today's session. So my hope is that by the end of the session, you'll be able to describe core health equity concepts, apply an anti-oppression lens to your social work practice, and to identify different frameworks and levers that can be used to support health equity action. And so our agenda for today is, first of all, the opening and welcome, which we're in right now, then setting the stage and describing some of those core health equity concepts, reframing our understanding around what is the problem of health inequity and where do we need to intervene to advance health equity. What are some of the different resources and tools to action health equity work in your social work practice? A brief interactive case study, and then a closing and discussion and thank you. So as a way of positioning myself, I thought it would be helpful to share a bit about myself so you have some insight into what is my social location and the worldviews that I bring to my work. So you'll see a few different images up on the slide. And even though I live in, a huge urban center in central Canada, in Toronto or Treaty 13 territory, I'm a huge lover of nature. And so some of these images from a park close by to where I live with my husband, where we regularly go. And also there's a couple of photos from different travels that we've taken in Canada, specifically in Quebec. We had a really nice summer holiday last year in Chelsea, Quebec, just on the other side from Ottawa, and it's a beautiful place. So I really got my dose of nature, which I always really appreciate. So I'm biracial, of Indian and white descent. I'm an immigrant settler woman. I use she, her pronouns. I come from a middle-class family. So the question that I need to ask myself is what is my responsibility as a critical ally and as an immigrant settler to this country to help redress ongoing injustices of settler colonialism. So, for example, this could include knowing the Truth and Reconciliation calls to action, the need to work in solidarity with Indigenous-led movements, to speak to family, friends, and others about how this system of oppression plays out in everyday life. And as Annette mentioned, I'm a registered social worker with the Ontario College of Social Work and Social Service Workers. I graduated from the University of Toronto with a graduate degree in social work. And I've worked in a multitude of different contexts, practicing social work at meso and macro levels, never at the micro level, but only ever at the meso and the macro level. And I think you'll see that emphasis reflected throughout this presentation. And we'll delve more deeply into the question of social location a bit later into the presentation. So now I would love to hear more, a bit more about you and who is joining us. So if you could take just a few seconds to share which province or territory are you joining from? So are you coming from the East Coast, from Newfoundland and Labrador? Are you coming from any of the Northern Territories, including Nunavut, Yukon, and the Northwest Territories? Are you coming from the prairies, or are you coming from the West Coast? So please take just a couple of seconds to respond to the poll, and then I will launch the poll so that everyone can see the results. Okay, so thank you for participating in that poll. And so we have 67 participants who participated. And so the majority of you, close to 40%, are coming from Newfoundland and Labrador, a few from Nova Scotia and from New Brunswick and Prince Edward Island. So this is really interesting to see that most of you are coming from the Atlantic provinces. So thank you so much for participating in that poll. And then the next poll that I would invite you to participate in is, what is your level of social work practice? So as I mentioned, I've only ever worked at the meso and macro levels of social work, but I'd be really interested to hear from you if you practice social work either as a micro social worker, a meso social worker, or a macro social worker. Or it's also quite possible that many of you work at multiple levels of social work practice. So I'll just wait a few seconds for people to respond in to the poll. And thank you so much to those people who are commenting in the group chat about where you're coming from, that you live in Ottawa and you were born in Cape Breton, Nova Scotia. So this is fantastic to see. So I'll now move to viewing the result and sharing that with everyone who is taking part in the session. So as we can see, many of you work at the micro levels, so 42%. A handful of you work at the meso and macro levels. And again, many of you, 44% or 45%, work at multiple levels of social work practice. So this is really great to see such a variety in the different contexts that you work in. So my ask of you, as you're listening to this presentation and as a part of your social work reflexive practice, is to really keep in mind these questions. So what insights are landing for me? How do I feel during this learning and unlearning? And what are my next steps in learning or taking action to advance health equity? And I want to thank Dr. Stephanie Nixon, who's the Vice Dean of Health Sciences at Queen's University, for these very insightful and slightly adapted questions. And we're asking you to identify how you're feeling, because if there's discomfort, it's an opportunity to explore and interrogate further. And it's a good signal for both learning and unlearning. And I do encourage you to take care of yourself, especially for people who experience different forms of oppression. So take a break, have a cup of tea, relax, and really engage to the extent that you feel comfortable with the content that I'll be sharing with you. And we will circle back to these questions at the end of our session together as a reminder, and to ask if anyone would like to share any reflections. So moving on into setting the stage and some core health equity concepts. So given all of you are social workers and practicing at multiple levels of social work, or very much at the micro level with a handful of you working at the meso and the macro levels exclusively, I just wanted to bring your attention to the Canadian Association of Social Workers Code of Ethics, which provides an overview of values, principles, and standards of conduct for all social workers across the country. So right now, this code of ethics is being updated using principles established by the Truth and Reconciliation Commission, and they are intended to be available in 2024. But they have noted that they anticipate that the same 6 values will be reflected in the refreshed version. So one of the core values reflected in the Code of Ethics is the pursuit of social justice. And I wanted to highlight this as there is clear alignment between the values and goals of social justice and the values and goals of health equity. So this focus that I'm taking on health equity is very much interconnected and linked with your work to pursue social justice. Since many of you are coming from Newfoundland and Labrador, I wanted to share a bit of information about the policy context there. So the College of Social Work has a health and social policy advocacy guide. And so it notes in that social work is committed to enhancing the health and social well-being of individuals, families, and groups and communities, and that social work has 4 main functions. So one is to provide direct counseling and therapy. So, focusing on the micro level, which many of you focus on, to develop, implement, manage, or deliver different kinds of human service programs. So functioning more at the meso level, and then contributing to the development and advancement of health and social policy, which is at the macro level, but can deal with micro and meso social work issues as well. And then conducting research into the practice of social work. And throughout these different domains of social work practice, there's a really strong emphasis on advocacy and for social workers to engage in client and systemic advocacy. The other thing that I wanted to draw your attention to is that Newfoundland and Labrador has recently established a 10-year health accord, and you'll see the 6 core areas of focus reflected in the hexagon on the right. And the vision for this health accord is to increase awareness of and interventions in social factors that influence health, i.e. the social determinants of health. So a focus on social determinants of health is embedded into the policy context at this provincial level. And some of the other core elements of the Newfoundland and Labrador Health Accord include community care, hospital services, focusing on aging population, quality healthcare, and digital technology. So now I would invite you to share in the group chat, what does health equity mean to you? So this might be words that come to your mind when you think of health equity. This might be potentially a definition of what does health equity mean to you, or values that are associated with health equity. So I'll just pause here and see if anyone would like to share any ideas around what does health equity mean to you? Fantastic. Yes, inclusive care, accessible and judgment-free care. Absolutely. And we will be speaking to that a bit later on in the presentation. Fair opportunity for healthcare. Absolutely. That is the notion of fair is definitely a concept that is referenced in definitions of health equity. Removing systemic barriers, fairness and equal treatment for everyone. Fantastic. This is all very much connected to what is health equity and some of the actions that we each need to take as social workers to advance health equity. Thank you so much for taking part in that brief group chat conversation. So in terms of health inequities, I'll focus on the negative first. These are really avoidable differences in health that are due to structural and social disadvantage, which some of you mentioned in the group chat. They're systemic, meaning they're patterned and they're not random. They're modifiable and avoidable, meaning that they're rooted in societal choices that can be changed and transformed. We know that they're not a result of natural biological differences. They're instead the result of how resources, power, and opportunities are distributed, and they can be changed through collective action by you and by us as social workers and other individuals, organizations, communities, and government. And we know that they're unfair and unjust, and that action to address inequities requires a commitment to social justice and human rights. For example, increasing access to clean water, food, education, housing. And we also recognize health equities as unfair and unjust, as it's an ethical principle that can help to guide resource allocation according to need and not based on wealth, power, and prestige. So this is a bit of a deep dive into the provincial context in Newfoundland and Labrador. So you'll see on the right some information that was shared in the Health Accord for Newfoundland and Labrador, which is really comparing the provincial situation with the rest of Canada as it relates to life expectancy, disease rates for cancer, cardiac disease, etc. And as you can see, there are real geographic inequities between Newfoundland and Labrador and the rest of the country. But when we do a bit more of a deep dive into what's happening within the Newfoundland and Labrador context, and just looking at this specific indicator around anxiety, the percentage prevalence of anxiety disorders, we can see that amongst adults who are aged 18 and over, the percentage prevalence is 12.27%. But when we drill down and look at that same indicator by education, income, or identity, these percentage prevalence rates shift significantly. So for example, if you look at people who have less than a high school education, the percentage prevalence for anxiety disorders shoots up to 19.86%. If you look at this indicator by income, for people who are living in the lowest income quintile, again, the rate of anxiety disorder goes up to 21.61%. So a pretty significant increase from the overall indicator for the general population. And then if we look at identity, for First Nations people who are living off reserve, again, the prevalence percentage is much higher at 15.85%. So this is actually a really handy tool that I just learned about very recently called the Pan-Canadian Health Inequalities Tool. And I believe that these slides will be shared with you afterwards. So I have included hyperlinks in the slide so that it will give you direct access to the specific website where I got this information from. So what is our vision for what we're working towards? And I think many of you already mentioned some of this in the group chat. So we're really working towards health equity, where all people have fair access to and can act on opportunities to reach their full health potential, where people are not disadvantaged by different conditions, including social and economic conditions, and they're not disadvantaged by different socially constructed factors like race, sexuality, gender, and religion. But what are the roots of health inequities? How are health inequities created? And again, some of this you were already referencing in the group chat, and thank you so much for sharing your perspectives on these questions. So one of the roots of health inequity is the different social determinants of health, which include the different intersecting social, political, and economic circumstances where we each are born, grow up, live, work, and age in. And they're really the conditions of daily life that intersect to impact health. But moving even further back, what are the social determinants of health influenced by? And these are really the structural determinants of health. And these are processes that create inequities in money, power, and resources. And they include political, cultural, economic structures, natural environment, climate change, history and legacy, as well as ongoing colonialism and systemic racism. So the structural determinants of health really intersect and shape the social determinants of health. So in this next slide, what you'll see is a framework from the Pan American Health Organization, which really puts together how the structural drivers influence and shape the social determinants of health, which are the conditions of daily life, and which then in turn influence the extent to which either health equity is advanced or health inequity is advanced. And there are opportunities for us as social workers to intervene at different levels to influence the structural drivers or the structural determinants of health or the social determinants of health in positive ways to advance health equity. So on this set of images, these are really different approaches to apple picking, but obviously it's a bit of a metaphor for how we organize our society. So looking at the top left-hand image, this is about inequality. So as you can see, the tree is structurally bent towards the left, giving the person on the left unearned advantage to be able to access apples on the tree. You can also see in the image that on one side of the tree, there are fewer apples. So not everyone is getting their needs met. If we move to the top right-hand image, this is equality, where you can see the same type of intervention as the ladders are positioned at the same height, still do not meet everyone's needs because, again, of the structural disadvantage as the tree is bent in one direction. And then the bottom left-hand image is equity. So things are definitely getting better. You can see there are now different sized ladders that allow everyone to reach the apples. But then you move to the last image in the bottom right-hand corner, and that is justice. And that is really about transformational structural change. So you can see that the tree is much straighter now through the addition of these supports, and that fruit is plentiful across all parts of the tree so that everyone is able to access this particular, beautiful set of apples. So achieving health equity really requires us to acknowledge that some people have unequal starting places and that different strategies are needed to correct these imbalances and to make health equity possible. So I just want to go back again to making an explicit connection between health equity and social justice. So on the left-hand side, this is the definition for health equity that I had referenced earlier, which comes from the NCCDH's glossary, which is a very handy overview of different terms in the health equity field. But you can see that there's a lot of intersections between this definition of health equity and social justice and the role of social workers on the right. So on the right, you'll see that the role of social workers is to uphold the right of people to have access to resources that meet their basic human needs, and that a role for social workers is to advocate for fair and equitable access to public services and other forms of benefit, and to advocate for equal treatment and protection under the law, and to challenge and to disrupt injustices. So this is just sort of a way of really connecting concepts of health equity back to your social work practice, whether you're working at micro, meso, or macro levels. And also on the bottom of the slide, you'll see a quote from the Commission on the Social Determinants of Health, where they say very correctly, and unfortunately so, that social injustice is killing people on a grand scale. So we have our work cut out for us. So this next section is around reframing what is the problem. So all of this section is really building on Dr. Stephanie Nixon's work, who I mentioned earlier, who is the Vice Dean of Health Sciences at Queen's University. And she's done some amazing work around the role of critical allyship and the COIN model of privilege, which I will share a bit of information with you in this next section of the presentation. But before I start diving into that particular model, I wanted to open up the group chat again and invite you to share with all of us who are participating in this session, who do you think of when you think about health inequity? And I see that, based on some of the previous responses, there have been sort of a few responses which start to address this question of who do you think of when you think about health inequity? So I'll just wait for a few seconds for people to start sharing in the chat some thoughts that come to your mind when you're thinking about responding to this question. Perfect, thank you. Yeah, a few of you have mentioned people who live in the downtown east side of Vancouver, people who are First Nations and who experience homelessness or houselessness, marginalized groups, people living with disabilities, Indigenous communities, people who use substances, seniors. And one person has said they can think of people of individuals who have limited access to health due to poverty. So this is fantastic. And everything that you've put in the chat box is absolutely a part of the conversation that we need to have when we're talking about advancing health equity and addressing health inequities. So one of the things that Stephanie talks about in her article is really reframing our thinking around what is the problem. Because as we all know, how we define what a problem is shapes what are the range of potential solutions. So this quote from her article, and you'll see there's a hyperlink at the bottom of this slide, which you can have a look at post session. In this quote, Stephanie is really talking about how if inequity is framed exclusively as a problem facing people who are marginalized, then responses will only attempt to address the needs of these groups without addressing the social structures or the systems of inequality that cause these disadvantages, or the complicity of the corollary groups who receive unearned and unfair advantage from these same structures. So this approach is often called an anti-oppression approach, which I think many of you as social workers will be familiar with. So this is a visual of the COIN model of privilege and critical allyship. And it really focuses on understanding how systems of inequality offer either unearned advantage or privilege, or disadvantage oppression. And the purpose of the model is really to inform action to resist and dismantle these unjust structures, i.e. the systems of inequality that you see in the middle that produce inequities. So you'll see that systems of oppression or inequality like racism, homophobia, transphobia, settler colonialism are metaphorically represented on this slide by a coin. And you experience either unearned privilege or unearned oppression, depending on which body you're born into and who you happen to be. So if you experience unearned privilege, you're on the top of the coin. And if you experience unearned oppression, you're on the bottom of the coin. And the goal is not to move people from the bottom of the coin to the top. Instead, the purpose is to dismantle the system of inequality, which is unfair and unjust, and causes outcomes which are unfair and unjust. So often in conversations, the systems of inequality and privilege are often made invisible. And I think the beauty of this particular model is that it really explicitly articulates this much broader view of thinking about health inequality and health equality or health equity. So this visual of the model starts to depict some of the complexities of how we each have unearned advantage and or unearned disadvantage due to multiple intersecting systems of inequality. So this really leads to conversations around how each of these different systems of inequality create intersectional identities. So as an example, if you happen to be white, you experience privilege due to racism and white supremacy. But if you happen to also be trans, you experience oppression due to transphobia. And if you also live in poverty, you experience oppression due to classism. So you can really see how complex a person's social location can be when viewing each person's identity through the prism of this coin model. And I want to emphasize this is not about innocence or guilt or the intent of people who are on the top of a coin of different systems of inequality. It's more about the impact that one's actions or non-actions have in upholding systems of inequality. So this view of health inequity opens up a far greater range of potential solutions to address inequities beyond only ensuring equitable access to service for people made to experience marginalization. I want to emphasize that is still very much an important part of advancing health equity, but it's only one of several different components of work around advancing health equity. So some of the other potential opportunities for change and for solutions that arise through this expanded view of work to advance health equity would include advocacy for change to policy and legislation, would be working in solidarity with and following the leadership of people made to experience oppression, as they possess expertise in how different systems of inequality function and what their specific impacts are. Which then moves us on to thinking about ways to practice critical allyship. And again, this is all very much from Stephanie Nixon's paper, so I do encourage you to take a look at the paper because I personally found it very useful, and it has really helped me to reframe my thinking around all the different components of health equity work. So as I mentioned, one way to practice critical allyship is to work in solidarity with people experiencing oppression. And for me, as an individual social worker, to recognize where I hold privilege, and then to use this understanding to reorient approaches from saving unfortunate people to working in solidarity and collective action on systems of inequality. And then it's also about deep learning about the different systems of inequality, particularly where you hold privilege. So for example, I'm middle class and I'm very fortunate. I have financial resources to be able to live in a nice place, to buy good quality food, and all of that gives me privilege. But then that requires me to learn more deeply about the system of inequality, which is called classism or poverty. And then it's about stepping back and creating space for others where you do hold privilege, and listening more and talking less and sharing power with and not over. And moving beyond action at an individual level to also focus on action at organizational and system levels, because that is what drives the inequities that individual people experience at the individual level. And to really focus on seeing critical allyship as not about increasing personal power, but about working in solidarity with others. So I realize that's a lot of content to have listened to and engaged with. And so I just wanted to share these reflection questions for you to reflect on both now as well as after the session as a part of your social work reflexive practice, and to consider what is your social location. How does it give you either unearned disadvantage and or unearned privilege? How does your social location influence your worldview and also influence how you perceive the people you're there to support? So I'll just pause there just for a few seconds for people to just quietly reflect on. If you'd like to share any reflections in the group chat, absolutely feel free to. But I would encourage you to take these questions with you and to continue reflecting on them as a part of your social work role. Thank you for that. So now we're moving on to the next section in this session, which is really about how do we action health equity, and what are some frameworks and levers that you can use in your social work practice to do this work. Because this is a question that we often hear from different public health practitioners from across the country, is how do we implement health equity? Because as we've seen, and as you already know, the extent and the depth of work required to advance health equity is vast and it's complex. And it requires disruptive thinking, strategy, leadership at all levels in social work and across different sectors to advance health equity and social justice. So what are some frameworks and levers that you can use to action health equity at individual micro, meso, and macro levels? So one of the things that we've recently done at the NCCDH is we've recently done a couple of reviews of the literature on health equity frameworks. You might ask, what is a health equity framework? The way that we defined it for this particular review is that provides some type of structured guidance on ways to move forward and act to achieve equitable processes and outcomes. So some different framework components, which you'll see in a few slides, can include things like, what's the goal of the framework? What are the specific steps or actions that this particular framework suggests that you take to advance health equity? What are some of the underlying values and principles? So as you can see in this slide, I've shared a few reasons why a health equity framework can be very useful. So it includes things like it's a tool that you can use to continue amplifying social workers' leadership and advocacy role to action health equity in practice. It's a tool that you can use to help disrupt systems of oppression and advance equity in whichever context you find yourself working. It's also something that you can use to build shared understanding of core health equity concepts. Like, what does health equity mean? What are the structural and social determinants of health? What's an upstream approach? What's a downstream approach? It's also a way to create momentum for health equity work as central within your program or organization or system, depending on which level of social work you practice at. And it's also a tool that can provide, as I mentioned before, and as you've probably gotten from the definition I shared earlier, it can provide flexible, actionable guidance, loose guidance on ways to move forward together to achieve or to advance health equity. So now that I've shared all the reasons why you might want to consider using a health equity framework, I'll also share with you some cautions and considerations. So frameworks are only one tool. And as they are created often in deeply inequitable contexts, you can't necessarily assume that they are only good. So if you're looking at different health equity frameworks, you need to carefully consider and assess the relevance and applicability in your context. Does it fit? Does it reflect the voices of people who are experiencing different forms of oppression? And will it help you to advance health equity and to dismantle and disrupt different systems of oppression? The other really interesting thing that we found in this review was that none of the included frameworks provided in-depth implementation guidance, which suggested to us that there is no right path to advancing health equity. And you don't need to have all the answers before starting on this work. It requires trial and error, an opportunity to innovate. And also, I want to emphasize the importance of evaluation, because we don't necessarily know a lot about what works to advance health equity and what does not work to advance health equity. So I really encourage you to apply evaluation to any health equity interventions that you undertake. And the other thing, as we've talked about earlier in this session, is that how we bring ourselves as human beings to this work really matters. So as mentioned, we each have our own worldviews, biases, and taking the time to both learn and unlearn as is needed can really deepen and strengthen the health equity work that you do. We know that health equity work is really complex, iterative work, and how we work together with different people, including people made to experience different forms of marginalization, matters just as much as the outcome. And as I think I've mentioned before, fundamental to all health equity work is a focus on disrupting different systems of oppression, including racism, sexism, poverty, and considering ways to really deeply share power at all stages when either co-creating, co-developing, co-implementing, or co-evaluating a health equity framework. So one of the frameworks that we looked at, which was developed specifically in collaboration with Aboriginal and Torres Strait Islander peoples in Australia, states, listen to us, work with us, journey with us, partner with us to create the future we want for our children. Learn from the past, trust us to lead. So the other interesting finding from these reviews that we've done is that while many of the included frameworks focused on advancing health equity for Indigenous peoples or people who are racialized, there were several other frameworks that were focused on advancing health equity more generally, but they still identified disrupting racism as a core element of advancing health equity. And then the last consideration that I'll share with you around using health equity frameworks is that given that Canada is a white settler colonial state, and we know there is federal legislation to advance and implement the United Nations Declaration on the Rights of Indigenous Peoples and the Truth and Reconciliation Commission calls to action, consider ways in which you can position both Indigenous and Western knowledge systems as equal in your work. So some suggested approaches that we came across in the review include things like ethical space and two-eyed seeing. And if people are interested, I can share some more of those resources afterwards with Annette for Annette to share with people who took part in this session today. So I'll move on to sharing information about three of the frameworks that we looked at. So one was focused very much at the individual level. And even though you can see in this title, it was focused on nurses, I would say that the suggested actions can also apply to social workers who are working at that micro level. And this framework is focused on guiding nurses or social workers to operationalize cultural safety and trauma and violence-informed care at the individual level. So some key dimensions of trauma and violence-informed care and cultural safety that this framework talks about is the need to attend to unequal power relationships, consider how structural inequities impact health and healthcare, focus on establishing trusting and collaborative relationships. So the framework notes 3 barriers to care, in this instance, specifically for Indigenous people experiencing marginalization, along with associated areas for action. So one of the barriers that they talk about is the intrapersonal. So some of the beliefs, values, and assumptions held by practitioners, which are also very much influenced by the discourse that takes place within organizations or within society. And so the way to address this potential barrier is to start with ourselves and to practice reflexivity at the micro level. Another barrier that this particular framework identifies are the persistent negative experiences of healthcare and the practitioner-patient relationship that Indigenous peoples have experienced. And so the way to act to address this particular barrier is to really focus on the quality of the interaction with your client or with the patient who you are working to support, and to prioritize that relationship. And then a third barrier that this framework talks about is the historical and social conditions and the policy and legislation that Indigenous peoples continue to experience now. And a way to help to address this is as individual practitioners, as social workers or as nurses, is to really consider that larger context of settler colonialism and policy and legislation, like, for example, the Indian Act. So, for example, with the death of Joyce Echaquan, that I'm sure all of us have heard about, the Quebec coroner who presided over the inquiry into her death said that she believes that Joyce Echaquan would still be alive today if she were white. So I'll move on to another framework that we identified through our review. And as you can see in the title, this is focused on improving Indigenous cancer journeys, specifically in BC. And it's really a pathway and process for care across organizations and systems. And it's both for service providers as well as Indigenous peoples going through a cancer journey. And I think what's really amazing about this particular framework, as you can see in the visual, is that it positions the framework in the context of land. And so the same 7 framework goals are situated as stepping stones in a river, moving from knowledge development all the way over to survivorship. And they're supported by the sands of living well. So some of the strengths of this particular framework include there were a number of different organizations who worked together to engage communities to learn more about Indigenous cancer journeys in BC. So that included the First Nations Health Authority, Métis Nation British Columbia, BC Association of Aboriginal Friendship Centres, as well as BC Cancer. And one of the quotes that they shared in this framework was, "We heard many stories of our brothers and sisters who have been through the cancer journey, and we wanted to make sure that the wisdom of Indigenous cancer patients, survivors, and their caretakers are reflected in this strategy." So this roadmap is very much built on First Nations and Métis Nation perspectives on health and wellness, cultural safety, cultural humility, shared decision-making, and traditional wellness. So as I've mentioned, there are 7 framework goals or areas of action to focus on. I'll just mention a couple of them. So with the partnership one, which is right at the bottom left-hand corner in this beautiful view of nature, is that Indigenous communities are there to guide cancer care services in alignment with Indigenous priorities. And so as you can see, this is really about sharing power and deep collaboration. And then if you look towards the top of the river, where you see the stone, which says end of life, one of the things that this framework talks about is that the end of life journeys, perspectives, and wishes of Indigenous peoples are supported, as is the wellness of their families and communities. So this presents a very different and Indigenous specific approach to advancing health equity, specifically for Indigenous people experiencing cancer. Now I'll move on to another framework that is from the Ontario context and which can be used at the organizational and system level. So this framework provides guidance for individuals, including service providers and organizations and systems to take health equity action. And so the goal of this particular framework is to advance equity, inclusion, and diversity and address racism. And they also note that to achieve better outcomes for all patients, families, and providers within Ontario's health system, we must explicitly identify and address the impacts of anti-Indigenous and anti-Black racism as a part of our commitment. So you'll see that the framework is visually represented by a jigsaw puzzle. And in the middle are the 4 foundational pieces or actions, which include collection of health equity data, embedding priorities for health equity and strategic plans, investing in implementation through the allocation of financial and other resources, and in partnering to advance Indigenous health equity. And then the outer circle includes different areas of action and focus, including evaluation, which I've mentioned before is a really important element of all health equity work, and the identification of clear accountability mechanisms. So some of the strengths of this particular framework include that it has both an internal organizational and external system focus. So they're really sort of advocating for ensuring that the way that the organization functions internally is equitable. And you'll see this quote on the right-hand part of the slide, where they say that building an equitable system must start with creating a culture and environment within the organization that promotes equity and reduces disparities for its staff, with a further goal to translate this culture and supporting tools across the healthcare system. Because Ontario Health is a relatively new organization that really has oversight over the entire healthcare system in this province. Some other strengths of this particular framework is that it was co-created and co-developed, so it reflects the voices and perspectives of many different organizations and individuals. It also has a robust evaluation domain, so it really contributes to organizational and system learning about what works and what doesn't to advance health equity. And it also provides clear high-level guidance on ways to move forward with implementing equity in action. I also want to draw this internal-external focus back to the Newfoundland and Labrador College of Social Workers Social Policy Advocacy Guideline, where it talks about the ethical responsibilities to the workplace, that social workers should appropriately challenge and work to improve policies, procedures, and service provisions that are not in the best interests of clients, are inequitable, and are in any way oppressive, disempowering, or culturally inappropriate. So it very much is in line with roles of social workers as articulated by the Regulatory College in Newfoundland and Labrador. So these are some health equity implementation levers. So when you're thinking about change within organizations and systems, these are massive, complex pieces of work to take on. And these 7 implementation levers were identified based on a series of interviews with public health leaders in BC from 2014. And based on this set of interviews, authors identified this set of implementation levers to be able to first prioritize and center health equity in health or social systems. So these include ensuring that supports are provided for people who are championing health equity in your context. Really ensuring, and some of this is very much in alignment with the Ontario Health Framework as well, ensuring that health equity is explicitly articulated as a strategic priority, and which would then set the stage for health equity to be a priority in operational plans, work plans, and also individual work plans, the allocation of resources, ensuring that there's a coordinated approach within the program, within an organization, and across systems, so that people and organizations are working together. Prioritizing health equity as a system value, so people, you and I, working in these different contexts, have an understanding of why health equity is important. And also, really importantly, that we have the skills and the capacity to advance health equity. And then ways to integrate health equity into decision-making, whether it's budgetary decision-making, program design, hiring practices. So there are many different decision points in all of our contexts where we work, where there are opportunities to influence those decisions with a health equity lens. So moving right along, I will also sort of just share with you a brief case study. And if you would like to participate and share any ideas in the group chat, I would love that. I want to make this as interactive as possible. And so this case study that I'll share with you, and you'll see now on the slide in front of you, is just really an opportunity to think about potential interventions at micro, meso, and macro levels. And I recognize that many of you work at the micro level, but also many of you identified earlier in the session that you work at multiple levels of social work practice. So I'll just read the case study to you, and I'll also share that I do not have all the answers. What I have in the next couple of slides are just some suggestions, really drawing on some of the concepts and the frameworks and tools that we've talked about during this particular session. So the case study is Alison lives with her partner and 3 children. She lives with high levels of anxiety and depression. As a family, they have limited decent employment opportunities, limited family income, and they also experience food insecurity. Where they live is classified as a priority neighborhood. And what I mean by that is that, for example, in Toronto, the United Way of Toronto has sort of designated certain neighborhoods in the city as priority neighborhoods because either they have high rates of poverty or they have poorer health outcomes than other neighborhoods in the city. And so going back to the case study, historically, people from this community have had little trust in the community organization where you work as a social worker or in other similar kinds of organizations. You also know that your organization has done little to explicitly center health equity in its work. And so Alison arrives at your organization seeking support for her anxiety and depression. So my questions to you are, where would you start and what questions would you ask to advance the health of Alison, her family, and her community? And I think for all, all of you social workers on the line who work very much at the micro level, I think you will have tons of ideas and potential ways forward around, particularly at working with Alison to support her with her anxiety and depression. Then another question is, what are the social and structural determinants of health which are influencing Alison's health, her family's health, and her community's health? And at which levels of social work practice can you intervene? And who else do you need to work collectively to address these different levels? Because as we know, health equity work is not solitary, isolated work. It needs to be done collectively and in collaboration with and in partnership with many different people. So I'll invite you to share any ideas in the chat. And thank you. I see a couple of you have already started to do that, which is fantastic. And as I said, what you're seeing up on the slide, they're not necessarily the answers. These are just some potential considerations for us to think about. So I think that's a great suggestion that you made, Carrie, that you would ask Alison what she's done in the past to access support. And you would find out from her where are the barriers and support her with those. So that's really about some doing client advocacy to help her to access some of those other services that she needs. And yes, absolutely, if Alison is open to support, you would also want to work with her to build her capacity to the development of her own health concerns. Another place to start is also to start with ourselves as social workers, to acknowledge our own power and privilege, and to practice reflexivity and to challenge any of our own assumptions and biases. And to really prioritize relationships, to establish trust, and to ask appreciative questions. And some of those appreciative questions people are already sharing in the chat. And I think that's an excellent point that you're making, Jennifer, that you would start with Alison and what is she experiencing anxiety about? and asking her what she's already tried. So really taking sort of a strengths-based approach. And absolutely, as you're saying, Catherine, that you would start with acknowledging the skills and the abilities that she already has. And yes, another excellent point, analyzing the safety of the community. So all of this, I think, when I look at some of the points that I've shared on the slide under the second point, what questions would you ask? So absolutely, it is learning more about Alison's identity and her history and context, and acknowledging the strengths that she already has. And then connecting back to a couple of the comments already in the chat around analyzing the safety of the community. It's also about what is the community's experience of your organization and how has the community been engaged. And I love this suggestion that you've made in the chat, Carrie. Is there a possibility of community access and staff coming to the residents of the community rather than requiring the residents to go to the facilities they do not trust? So that's another excellent way of really sharing power, and then asking the community where would be a desirable location in that community for the medical staff and others to connect with people in the community who need some of those services that your organization is providing. So then the other question that I was asking is, what are the social and structural determinants of health which are influencing Alison's health, her family's health, and her community's health? So I've put in on the slide a few potential answers. As we know, her family has limited income and they experience food insecurity. So definitely one of the social determinants is income and social protection. What is working life, food security, and potentially housing? If Alison and her family experience limited income, then quality of housing could potentially be a factor. And I think in Toronto, where everything is so incredibly expensive, that then influences people's ability to find good quality housing. And absolutely the environment, poverty. Some other structural determinants, which really is looking more at the policy and legislative level, would include social and economic policy that really drives and shapes the conditions within which Alison and her family live and grow and age. Any other suggestions for other potential social and structural determinants? Otherwise, I'll move on to the next slide, which is really looking at some potential interventions at different levels, at the micro, meso, and macro level. So I think, as micro-social workers, many of you would already be very familiar with the provision of culturally safe psychosocial supports for Alison and potentially for her family as well. And some of you have already mentioned the need to do advocacy to connect Alison with relevant supports like income supports, education and training, cultural supports, and wellness. And then looking at the meso level, so the internal and external organizational context. So as you'll recall in the case study, you know that your organization has done little to explicitly center health equity in its work. So that's really an opportunity to use potentially an organizational or system framework like the Ontario Health Framework to really look at ways to center health equity in your organization. So are health equity and anti-racist approaches embedded at all levels of the organization, for example, in organizational values, in strategic priorities, in decision-making? Do people in your organization, including ourselves, have the competency and capacity to advance health equity? Is health equity data collected? Do you have a way to measure the impact of your interventions? And then doing advocacy for enhanced services and programs based on community need and design. And then at the macro level, looking at ways to advocate for more equitable social and economic policy. And potentially another thing that I haven't reflected on the slide is also to think about narrative change, because policy is also very much influenced by societal values and societal discourse and societal ways of thinking about people and programs and who deserves what. Even thinking about ways to shift the narrative to advance health equity is also another macro intervention that could be considered. And given policy advocacy work is huge long-term work, these are opportunities then to work in solidarity with and in collaboration with different coalitions and campaigns. And then also to look at the extent to which your policy advocacy work is aligned with existing government policy. So for example, in Newfoundland and Labrador with the Health Accord, they have centered a focus on advancing the social determinants of health, which provides a lot of space to really do advocacy work to advance policies that advance social determinants of health. So in closing, I would just like to, again, circle back to those tasks or questions that I asked of you at the beginning of the session. So this is just, as I mentioned, again, an opportunity for you to reflect on these questions and continue reflecting on these questions as critical allies. So what insights are landing for me? How do I feel, or how have I felt during this learning and any potential unlearning? And what are the next steps I can take both to continue learning and to continue taking action? And I'll leave you just with some key takeaway messages, which are really derived from everything that we've talked about throughout this session. So really think about centering health equity and social justice in all your work. Lives are at stake. And consider, as social workers, that you have a position of power and influence to advance health equity. And how will you share power and work in solidarity with people experiencing oppression? And who will you collaborate and partner and share power with? As we know that leading for health equity is very much collective relational work. And is it good enough to do excellent work for only some people? And maintain that belief that a healthier, more just world is possible. So on that note, I will turn my camera back on, and thank you so much for listening and for participating in the group chat. And I will hand it back to Annette to facilitate the Q&A session. Thank you so much.
Wonderful. Thank you so much, Nandini, for this excellent and informative presentation. So we have arrived at our question and answer period. And so I do encourage people, we do have a little bit of time if you do have any questions that you want to submit. And again, that's in the question mark widget to the left of your screen. So Nandini, I personally, reference the National Collaborating Center for Determinants of Health quite a bit and frequent the websites. Can you provide some more information around the work of the center and how people can access information and resources from the site?
Yeah, so I'll actually share on the next slide. So here, I believe, at the top, you can see the URL to the NCCDH website. And if you go to our website, we have many, many, many different resources. So some of our work is very much focused on core health equity concepts. And we cover some of those core health equity concepts in a series called Let's Talk. So we have Let's Talk Health Equity, Let's Talk Intersectionality, Let's Talk Roles to Advance Health Equity. And then we've also got other resources that really focus on different thinking related to different structural determinants of health, like racism, houselessness, settler colonialism. So the website is a great place to go and explore. We also frequently host webinars. So in fact, tomorrow we have part 2 of a webinar on intersectionality. So we have regular ongoing webinars. In fact, one of the webinars we will very likely be doing towards the end of June is a webinar on the Health Equity Frameworks review that I briefly mentioned. And also, if you have any questions, I am more than happy to share my work email and just share any questions or resources that you're looking for. Very happy to connect anytime. So I'll pop my email into the group chat. Thanks for that question, Annette. I hope I answered that.
Yes, yeah, no, it's a fabulous, the organization's a fabulous resource. And yeah, so it'd be good if people can connect, with the center and all the wonderful work and resources that are available there. Another question is around the determinants of health. And from your perspective, is there one that is more significant than the others? Like, how would you kind of look at the social determinants of health and the impact that they have on people?
Yeah, and I find that a very hard question to answer because I think it also depends on the context. So I know, for example, and of course I'm forgetting his first name now, but Raphael, who is a prof at York University, has done a lot of work on the social determinants of health. And he often talks about the importance of poverty and that without income, your ability to pursue full health is severely limited. Another thing that I've referenced several times, I think, in this presentation, and we're talking a lot about at the NCCDH, is also racism, because racism can also impact the extent to which you're able to access good income. So I would say that they all work very closely together to create situations of huge inequity. And I think the other thing I'll also mention is that, again, in the review of health equity frameworks that we looked at, and as I mentioned, even in the frameworks that were not focused on addressing racism, but were focused on advancing health equity more generally, several of those frameworks spoke to the importance of addressing racism in all health equity work. So that's what I would share in response to that particular answer, but I would very much focus on what is your particular context and challenging your own assumptions about what you think might be the most important social determinants of health to focus on.
Mhm. Yeah, no, that's excellent. Thank you. Another question. So we still have a couple more minutes if people want to send in their questions, but almost a leap off to the last question around social workers and how we've always approached our work from that person and environment perspective and understanding the impact that those determinants have on people. What's your opinion on what are some of the obstacles in advancing those determinants if we know what the issues are in terms of advancing those so that we ensure health equity for everyone?
Yeah, no, that is a great question. And I would say there's multiple factors which make this work very challenging. One is that, as I mentioned during the presentation, it's really the structural determinants of health. So societal values, policy, and legislation, which really drive those social determinants of health. So those are massive things to change. And it requires sustained effort to really influence change at those different levels and to influence societal values towards valuing full health equity. The other thing I'll also share is, as a part of our work around health equity frameworks, we've also been engaging with different organizations, and many of them large organizations, primarily in public health and healthcare, who are working on advancing health equity within their own organizations and then influencing health equity outwards with all of their different partners and others who either they fund or they influence as stewards of a particular type of strategy, health strategy. And it's because organizations and systems are complex and they're very rooted in doing things the same way. And to disrupt some of those organizational contexts takes, as I mentioned before, real strategy and leadership, and ideally support and engagement from the top levels of people within those organizations. So those are some of the factors which present barriers to advancing health equity. And I think I reflect on my own learning as well. So I've only been with the NCCDH now for about a year and a half now. And my own understanding of health equity has significantly deepened during my time with this organization. And sometimes what I've experienced myself is sometimes you just don't know what you don't know. And it requires deep thinking, reading, and reflection and discussion with others to really see beyond your blind spots. And we did that actually in one of the reviews of health equity frameworks. We engaged with some Indigenous advisors who really challenged some of our thinking and helped us to advance and see beyond where settler colonialism and a focus on Western knowledge systems was really playing a negative role in how we were doing our work. So I think it's also about, as an individual, being open to learning and being open and humble to challenging how I think as an individual. So there's multiple barriers, I would say, but multiple opportunities as well to advance health equity and social justice.
Yeah, oh, that's excellent. Thank you so much. And another question we just received, again, as a spin-off to that question, how can we effectively advocate for macro decision makers, so for example, provincial and federal governments, to consult with individuals and communities? So you just talked about that valuable learning. Is there any way that we can advocate for that consultation to continue with individuals and communities?
Yeah, so I'll just reflect on an interview I did recently with a municipality in Ontario. And I don't think the information is public yet, but I can definitely send a link to it once it is public. So that's why I haven't sort of shared exactly who it is. But so anyway, this particular municipality during the pandemic, they were wanting to roll out access to COVID-19 vaccines with a particular community that had historic experiences of racism, marginalization, poverty. And so they did not trust the municipality. And so the municipality was sort of going about rolling out this access to COVID-19 vaccines with this particular community, using its usual approach of being very top down, saying this is where the vaccines are available, come and get them. But they weren't engaging at all with the community in terms of how to do the rollout in an effective way. And so they realized when no one was showing up at these COVID-19 vaccine clinics that they needed to shift how they were doing their work. And so they started to go to community meetings and to go to other places where community leaders and community members were, and to start engaging with them and saying, what are we doing wrong? Why are you not coming to these vaccine clinics? And so this was public health within this particular municipality. They really had to shift their perspective. So instead of seeing themselves as the experts in the room, they had to acknowledge and listen to, and again, with humility, hear the expertise of community members and community leaders, and which then really shifted how they worked to roll out access to those COVID-19 vaccine clinics. But then what that entailed with the government, because all of this was being funded by the provincial government, was that they then had to push back with the provincial government to say, this approach is not working and this timeline is not working with this particular community. We need to do it a different way so that we can get vaccine rates up with this particular community. So required advocacy at the senior leadership levels in this municipality and in this public health unit with the provincial government. So again, that speaks to the need for support at senior leadership levels to be able to advocate and push back respectfully and kindly, but with a strong rationale as to why a different approach and a different timeline, a much more extended timeline, was needed to ensure that this particular community really did access the COVID-19 vaccines. So I think it's also being, I think, very politically attuned and strategic in how you advance health equity and who are the allies that you're working with. So as I mentioned before, you can't do this work alone because the change that is required is too huge.
Oh, that's a wonderful response. Thank you so much. And I think we have time for one last question. We'll try to sneak this one in. So someone had noted it in the chat, but also now as a question. So one thing that they're seeing a struggle with is the discourse, and I think it goes back to the image you show with the trees around equality and equity as well, but struggling with the discourse of increasing equity by increasing public access to service. And the person saying what that looks like in practice is that, seeing clients now from all different program areas without, changes in positions or roles and those kinds of things. So any thought on ways to approach that in terms of how we, actually view that from equality versus the equity piece within having those conversations within organizations?
So I'm not sure I fully understand the question. So it's sort of about the difference between equality and justice, or
yeah. They're
sorry, if you
struggling
could
with,
repeat the question for me.
yeah, no problem. So the struggle is with there's a discourse that we're increasing equity by increasing public access to services without, identifying, I guess, what the needs are. So clients are being seen from all programs without an increase in positions or roles from the social work perspective. Um, and tying that into workload.
Yeah.
So we not always support it with, changes with regards to one's workload.
Yeah. So I think that speaks to an element then within the Ontario Health Framework, which is about resourcing. And this work needs to be sufficiently resourced, and which then again goes back to decision-making processes within an organization, which goes back to budgeting, which then sets how many people can be hired to do this work, and do these people have the skills and competency and supports that they need to do this work. So I think it requires taking a whole of organizational approach. So instead of just sort of increasing access to services for people who are made to experience marginalization, which is definitely one very important element of advancing health equity work, it's the need to take a whole of organizational approach so that that people do really have the resources and supports that they need to do this work, and that it's valued within the organization as an organizational value, and that it is very clearly reflected within the organization from strategic priorities all the way down to unit work plans, down to individual work plans. So I think just taking sort of like a siloed approach to it is not necessarily the way to go. It's a starting point, but then it creates other problems in terms of workload. Thanks for that question.
All right, thank you so much. So that brings us to the end of our time. I'm sure we could keep going, but we are at the 1.5 hour mark. So I just want to take this opportunity to thank Nandini for facilitating this stellar webinar for us today. and for sharing her experience, expertise, and knowledge with us. And I saw some of the comments coming in through the chat, how they thought this presentation was excellent and amazing, lots of great information. And a lot of important information was shared. And we hope that you do take the time to reflect on the determinants of health and the impact these determinants have on the lives of the people that you work with on a daily basis. And regardless of whether you work in frontline service delivery, program management, policy development, this information and ongoing discussion on how we can work to advance those determinants and foster health equity is important. And Nandini, I want to thank you for taking time from your busy schedule to join us today and facilitate this session for us. It is truly, truly appreciated. Just want to note that registered social workers in Newfoundland and Labrador may claim 1.5 required CPE credits for attending this webinar as per our NLCSW CPE policy. For those joining from across the country, please check with your regulatory body on how you can claim this session and download the certificate of attendance from the webinar platform. Just want to reiterate that the PDF of Nandia's presentation is available in the resource section on the webinar platform. I did note that some people already had downloaded it, so that's wonderful. And NLCSW's policy statement on the social determinants of health, our health and social policy advocacy guideline document for social workers, and our explanatory document on cultural competence in social work practice is also available under the resource widget. And as you sign off, we do ask that you complete the evaluation that will appear on your screen. We certainly value everyone's feedback and look forward to reading those comments and feedback. So thanks again, everyone. Thanks, Nandini, for a great presentation. I don't know if you had any concluding thoughts that you wanted to share before we sign off for the afternoon.
I just want to thank everyone for taking time out of your busy days to connect to this session. And I'm really excited to stay connected if you have any follow-up questions. And thank you so much for all of the amazing work that you do in your different social work contexts.
Excellent. Thanks, Nandini. And thank you, everyone, for joining. Have a great rest of your day.